Thank you very much for the opportunity to present a recent study titled A Novel Approach to Optimizing Labor Analgesia Using Programmed Intermittent Epidural Bolus. My objectives for this talk are to summarize the role of programmed intermittent epidural bolus in labor analgesia, review the clinical benefits and disadvantages of PIEB versus continuous epidural infusions, or CEI, review the current evidence on PIEB delivery settings, and discuss a novel technique to determine PIEB pump settings. I'd like to first start with a brief history. Neuraxial anesthesia, which refers to both epidural and spinal anesthesia, was initially maintained by clinicians giving repeated boluses. With the development of infusion pumps in the early 1960s, labor analgesia improved and became less labor-intensive for staff. In 1988, patient-controlled epidural analgesia, known as PCEA, became available, and it allowed patients to participate in their care, and the satisfaction with labor analgesia improved. At this point, continuous infusion of local anesthetic provided by a pump with PCEA became the standard of care for labor analgesia for many years. Despite these advances, clinicians realized that delivering intermittent boluses was more effective than a continuous infusion for pain. And this is because epidural analgesia requires adequate spread of the anesthetic solution. You can see in this study, the spread through the epidural catheter with the 3.5 ml bolus is actually greater than with an infusion provided at 10.5 mLs per hour. In 2012, a new type of delivery system known as Programmed Intermittent Epidural Bolus was developed. This pump provided a way to give bolus injections using the convenience of a pump. In this video, you will see a small amount of solution exits the catheter when it's provided as an epidural infusion. When a PIEB bolus is provided, all three ports of the epidural catheter are used, improving the spread. PIEB delivers a volume of local anesthetic solution at fixed scheduled time intervals. The pumps have a number of variables that must be programmed into the software for the pump to work effectively. After the epidural procedure is complete, a manual bolus is provided by the physician. The time to the first PIEB bolus after the pump is started is referred to as the next bolus. The PIEB interval is the time interval between subsequent boluses. The PIEB volume is the amount of local anesthetic delivered with each program bolus. And finally, the patient-controlled bolus volume and lockout interval also need to be set, but they've usually been similar to the settings used for continuous infusions. Since implementation, studies have suggested advantages to the PIEB program compared to continuous epidural infusions for labor analgesia. This original meta-analysis from 2013 found that PIEB was associated with decreased local anesthetic consumption, improved maternal satisfaction, and decreased the duration of the second stage of labor when it was compared to a traditional epidural infusion. Several more years of clinical experience gave another systematic review and meta-analysis. This showed a decrease in the incidence of breakthrough pain, a reduction in patient-controlled local anesthesia use, and improved maternal satisfaction when PIEB was compared to continuous epidural infusions. There are some disadvantages that have been identified with PIEB. Safety concerns have been raised, specifically the occurrence of high block, which could be related to bolus timing or an unrecognized catheter in the dural rather than epidural space. PIEB can produce higher sensory levels than continuous infusions. In this study, almost 70% of the patients who were receiving a bolus every 30 minutes had a sensory level above the T6 dermatome, which can be a safety concern. Another potential disadvantage of PIEB relates to the way the patient-controlled function interacts with the regularly scheduled intermittent bolus. This interaction has the potential to provide inadequate analgesia due to the lockout settings of the pump. It is important to consider how PIAB affects labor and delivery outcomes compared to continuous infusions. This 2019 meta-analysis found a significantly shorter total duration of labor when PIAB was compared to continuous epidural infusions. This meta-analysis did not find a difference in the rate of cesarean delivery between PIAB or continuous infusion. Using PIAB for labor analgesia did show a reduction in the interventional vaginal deliveries, which would be vacuums or forceps, when PIAB was compared to continuous epidural infusions. When PIAB pumps were first introduced into clinical practice, there was no guidance about how to set the pump settings. Over the course of several years, researchers have tried to determine what are the optimal pump settings. This was one of the first dose-finding studies from 2011 that randomly assigned patients to PIAB volumes and intervals. They showed a local anesthesia sparing effect without sacrifice in analgesia when PIAB volumes were larger and there was longer time intervals between the scheduled intermittent doses. Another study found that the optimal time to deliver a 10 milliliter PIAB volume was approximately 40 minutes. The limited but available evidence suggests that larger volumes of dilute local anesthetic provided approximately every 40 minutes seems to be most efficacious. Recognizing there were still pump settings and clinical outcomes that needed further study, my team designed a clinical trial to help determine what is the ideal time to give the first dose of the bolus, known as the next bolus. The analysis for this trial is currently ongoing. The study I would like to focus on is a double-blind randomized trial that we completed in our labor and delivery unit of a tertiary care obstetric hospital. The study was novel in that it used a method not previously described to help determine the optimal PIAB volume and settings. It also examined the effect of manipulating 3 pump variables on clinical outcomes simultaneously. We included patients if they were nulliparous, English-speaking, and had an ASA classification less than 2. They had to be at full term and single gestation, in vertex presentation, and in spontaneous labor. Patients were excluded if they had known maternal cardiac disease, contraindications to epidurals, known fetal anomalies, less than 5 foot in stature or had a BMI higher than 45, had a cervical dilatation of greater than 7 centimeters at the start of the study, or delivered within 180 minutes from the study start. Participating patients were randomized by computer generation to a combination of predetermined pump settings for the PIAB next bolus, the PIAB volume, and the PIAB interval. Study outcomes were gathered within 24 hours of delivery from the epidural pump, the anesthesia database, and the birth unit nursing record. We chose clinical outcomes that were felt to be relevant to patients, referenced by the current literature, and safely used in our institution. The clinical outcomes were a maternal satisfaction score based on a visual analog scale, and we considered optimal response to be greater than 90. Next, we looked at the number of clinician or pump boluses that were delivered, and we considered an optimal response to be 0. Finally, we looked at the number of PCEA boluses delivered to the number of patient-controlled boluses requested, and we wanted the optimal response to be matched at close to 1. Upon request of labor analgesia, cervical dilatation was confirmed, and baseline pain score and blood pressures were recorded. An epidural was placed in the usual fashion, and local anesthetic bolus was administered by the physician using the catheter. The catheter was then attached to the PIAB pump. Physiological assessments for pain scores, blood pressure, sensory level, and motor scores were completed as per the birth unit protocol. Each patient had access to the patient-controlled epidural analgesia, which would deliver 6 mL of the pump solution every 10 minutes as required. If after 2 PCEA doses the pain was not suitably controlled, the anesthesia team could then provide an additional bolus, manually or by the pump. The mathematical model used in our study was called response surface methodology. or RSM. RSM is a collection of statistical and mathematical techniques used with a sequence of designed experiments to obtain an optimal response. RSM was chosen for the study due to its ability to analyze multiple independent variables and outcomes to generate a model that can be used for optimization. The study design minimizes time and cost by reducing the number of trials that is needed for the study. The first step in RSM is to select the independent variables and suggest possible ranges. In our study, the independent variables were the PIB pump settings. The range of the variables were the next bolus from 15 to 45 minutes, the PIB interval from 40 to 60 minutes, and the PIB volume from 5 to 8 mils. The next part of the design is called the design of the experiment. The most common design method is called the box-Benkin design, or BBD. BBD develops a box, as seen in this slide, where each point on the box represents PIB pump settings locally located at equally spaced intervals. In our study, there were 13 possible PIB pump setting combinations. The design suggested that 6 patients be randomly assigned to the pump settings on the surface of the cube and 8 patients at the center, for a total of 80 participants. The small sample sizes have been effective in non-clinical RSM study designs, but we increased the sample size to account for clinical and demographic differences and dropouts. Due to exclusions, the final cohort was less than our target, with a total of 69 participants. The third step in RSM is to fit the model equation to the experimental data and obtain a response surface. For each pump setting combination, RSM creates a stationary point that is then maximized or minimized for the 3 clinical study outcomes. Simulations were used to estimate confidence intervals for the stationary points, so the response surface of each outcome does have a measure of variation. The final step is the desirability function. The desirability function determines the most suitable conditions for 2 or more outcomes. In our study, the desirability function transformed the estimated response surface for the clinical outcomes to a desirability value. The desirability value was then combined into a single value for the combined clinical outcomes. RSM predicted that a PIB next bolus of 29.4 minutes, a PIB interval of 59.8 minutes, and a PIB volume of 6.2 mils was associated with a maternal satisfaction of 93.9%, a PCEA ratio of 0.77, and a need for clinician bolus of 0.29. There were no significant differences amongst patients randomized to the PIB settings in terms of side effects. The suggested PIB settings, when you isolate for a specific stationary point to achieve maximal or minimal clinical outcomes, are shown here in this table. The maximal maternal satisfaction could be reached was 94%, and this is seen in the first row. The minimal amount of clinician-delivered bolus was 0.11, seen in the second row. And the pump settings that were associated with the most optimized PCEA ratio of 0.89 was seen in the third row. To our knowledge, this is the first study to identify 3 pump settings for PIB simultaneously while optimizing 3 clinically important analgesia outcomes. There are some study limitations. First, in this study, all clinical outcomes were weighted equally in terms of importance, suggesting that patients value them equally in terms of defining labor analgesia. Future research should focus on patient preferences of clinical outcomes. Using this specific RSM methodology, changes in the PIB settings cannot be applied to each clinical outcome in isolation, and likely any change comes at the expense of accepting a lower value for one of the other clinical outcomes. Future studies using RSM could target obstetric populations with comorbid disease or multiparity. They could also consider alternate local anesthetic types when trying to determine the most optimal pump settings using PIBE. Thank you very much. Yes, thanks.
Hi, it's Annette from the IWK. How are you? It's good to see you online. Great presentation. We were having some conversations here around your study and thinking about, the practical applications and key messages out of it at the end. And for me, and please correct me if I'm wrong as we're having this conversation, it's around self-directed pain management appropriate for women. Obviously, every woman experiences pain differently. And so we want to find the kind of optimal range of that self-directed pain. We all agree women are experts in their own bodies. So this is awesome to support person-centered, women-centered care. And then from a resourcing perspective, if that is happening and women are managing their pain appropriately, then anesthesiologists and nurses and others can be busy doing other things on the birth unit because you're pulled in many directions and there's a lot happening. Am I correct in kind of summing that up for application?
Yes, I agree. And that's what they've shown with this switching to the PIB technique, and with us better learning what settings are appropriate. I agree. It has benefits to the patients in terms of obviously adequate pain control, but it also has system effects, like you said, because, especially in the setting that we are now with such scarce resources, it does free up, as you said, nurses, anesthesiologists to be attending to other things. And plus it empowers the patients, especially with the ability to still use that patient-controlled epidural analgesia button. So, patients often worry about having too much anesthesia or analgesia. So I think I think as we keep working towards the best settings, it'll have advantages, as you say, for patients and on the healthcare side as well.
Thanks very much. And for our online participants, I'd ask that you please use the Q&A function that you see so that we can collect your questions. But right now, I'd like to welcome Dr. Erin Kelly to make her presentation.
Good morning. Thanks so much to the partners in Women's Health Research and Women's Health Collective Canada for allowing me to showcase our clinic and our research today. I feel I need to preface my talk by saying I'm not a natural public speaker, so I have my notes here. And actually, many of my clinical colleagues are here in the audience, which is really great. Thanks for coming. And if there's any questions at the end, I may defer to you as well. So sorry, here we go. Maybe not. It's okay. Just switch screen 100 times. Okay. There you go. Yeah, easy. So I'd like to start off with a brief overview of what we do in our chronic pelvic pain clinic at the Lois Hole Hospital for Women here in Edmonton, and how we approach pelvic pain. And then I'll go on to some of our active and ongoing research projects. Thank you.
A little closer to the mic.
Okay. Is that better? Perfect. So we are the chronic pelvic pain clinic here at the Lois Hole Hospital for Women in Edmonton. I'd like to start off by just telling you a little bit more about our patients. So our patients are referred from gynecologists, primary care providers, urologists, and general surgeons, among other subspecialists. Often our patients' pelvic pain, is refractory to standard treatments and procedures. They often feel that their pain story has been dismissed and even ignored by many healthcare providers. They often arrive to our program disheartened and with little hope for recovery. Management of chronic pain and chronic pelvic pain specifically is complex and multifaceted and requires a biopsychosocial approach. In our clinic, we strive to address and manage all aspects of the biopsychosocial model seen here for our patients, but we aren't quite exactly where we want to be just yet, and we're hoping to get there in the near future. So what we offer right now, a patient referred to our program will be offered a pain education class given by our nurse, clinical nurse navigator and physiotherapist. And I should say they developed it as well. A medical consultation with a gynecologist and subspecialty trained in female pelvic medicine, or also known as urogynecology, with a special interest in training in chronic pelvic pain. And that's myself and my two partners in pain who are here today. A medical consultation with a family physician with a special interest in women's health and chronic pelvic pain, consultation with a pelvic floor physiotherapist, consultation with a hypnotherapist, mind-body integration specialist, access to a kinesiologist-led exercise class developed specifically for our CPP patients. And finally, I forgot it on the list, unfortunately, but it's a very important part of our program, the mindfulness cognitive behavioral therapy group class that's led by my colleague, Dr. Sinai. Where we want to be is we want to be able to offer our patients a consultation with a dedicated clinical pharmacist with specialized training in opioid therapy management, treatment plans, and patient contracts. We'd love to have a dedicated CPP, psychologist, or counselor with training in trauma and PTSD, as this is often a barrier to treatment for a lot of our patients. We'd love to have a dedicated CPP social worker with access to community resources and supports for our patients, as this is often another barrier. And finally, we'd love to have a dedicated research lead with admin support to push our research through to knowledge translation and dissemination. Moving on to our research projects, our research is investigator-led with generous support from the Alberta Women's Health Foundation through the Women's and Children's Health Research Institute, known as WICRI. I'm excited to tell you more about some of our ongoing projects. First, I'm going to talk to you about our systematic review of pelvic floor injections for chronic pelvic pain. In our CPP program, we routinely perform pelvic floor muscle injections as an adjuvant treatment to physical therapy, psychological therapy, and analgesic medications. There is, however, a paucity of scientific evidence for the mechanisms of action of these, as well as their overall benefit. We set out to perform a systematic review to find out what the optimal treatment for our patients should be. Myofascial pelvic pain is a functional pain condition in which patients can be found to have short, tight pelvic floor muscles, or what is also known as trigger points. This syndrome is often associated with long-standing pelvic visceral pain syndromes, such as endometriosis, a history of trauma or abuse, or other chronic pain syndromes, such as temporal mandibular joint syndrome, migraines, and fibromyalgia. While the effect of injection into the myofascial trigger point is not well understood, there are several theories as to their mechanism of action, including, for example, disruption of muscle fibers or interruption of a positive feedback loop, to name a few. For our project, we started out with 841 identified articles with our search strategy, and after eligibility and screening, we ended up with 49 articles that met our criteria for review. Overall, 9 of the studies we found were randomized controlled trials. 17 of the studies were prospective cohort studies. 13 of the studies were retrospective cohort studies, and 10 of the studies were simply case reports or case series. As far as intervention, Botox was used in 31 of the studies. Local anesthetic was used in 10 of the studies, and both local anesthetic and Botox injections were used in 8 of the studies. Our conclusion overall, following the narrative analysis, was that injection of either local anesthetic or Botox may be effective for the management of chronic pelvic pain. Due to significant heterogeneity among the studies, we could not pool the results, and instead we had to perform a narrative analysis. The randomized control trials of both either injectable local anesthetic or injectable Botox reported significant improvements in chronic pain scores when the groups that received the intervention were compared to their baseline scores. However, none of these trials demonstrated a significant benefit in pain score when compared to placebo. So there seemed to be no benefit of local anesthetic or Botox over placebo. However, yes, there was an improvement seen in chronic pelvic pain scores in the group that received placebo when compared to their baseline pain scores. More high-quality studies are needed to further clarify the benefit of this treatment modality. I'm going to move on to our cannabis study. This was a study that looked at patients' attitudes and perceptions towards cannabis for the management of chronic pelvic pain. This summer student project was supported by the Alberta Women's Health Foundation through the Women's and Children's Health Research Institute. The therapeutic use of CBD has been studied in multiple chronic pain syndromes, but not specifically chronic pelvic pain. CBD exerts its effects by influencing the release of cytokines, chemokines, immune cells, and seems to have an effect on inflammation and immunosuppression. Cannabis has shown promising effects in the treatment of chronic pain and is also associated, importantly, with lowering the dose and/or prescribing of analgesics, including opioids. We performed a prospective survey-based cross-sectional study within our CPP program here at the Lois Hole Hospital. We recruited a total of 98 participants with an overall response rate of 80%. 51% of our participants reported using cannabis for medical purposes to manage their chronic pelvic pain. And of non-cannabis users in the study, 50% reported an interest in trying cannabis for the treatment of their CPP. Within the groups of participants reporting cannabis use, 28% reported it was very effective to manage their chronic pelvic pain, while 40% reported it to be somewhat effective. Overall, 42% of cannabis users reported using cannabis allowed them to decrease use of their other medications to manage their pain, including analgesics, including opioids, sedatives and sleep aids, and antidepressants. Overall, cannabis use had a more positive effect on quality of life, physical health, and mental health, and there was very little perceived or reported perceived negative effect on the functioning categories we investigated. Moving on to one of our newest initiatives in the clinic, the Mind-Body Integration Program, which we also call the Hypnosis Program, is a relatively new initiative for us. My colleague, Dr. Poirier, who's here today, and her team, supported by the Wickery Summer Studentship Grant, funded by the Alberta Women's Health Foundation, set out to explore patient and provider experiences of this new initiative as it was rolled out for us. What exactly is hypnosis? Well, hypnosis is a state of consciousness involving focused attention and reduced peripheral awareness, characterized by enhanced capacity for response to suggestion. And it has been shown to decrease pain and improve quality of life in patients with chronic pain. And in some cases, it's even been shown to be more effective than physical therapy and education alone. The team conducted in-depth interviews with CPP practitioners whose patients had attended the Mind-Body Integration program in our clinic. This was a qualitative analysis. From these interviews, several themes emerged. However, the most overwhelming theme was healthcare system gaps. It came up several times in the interviews that the hypnotherapy program, or the Mind-Body Integration program, at our clinic had provided patients with a holistic approach to their condition, bridging the gap between the physical and the psychological dimensions of chronic pelvic pain and providing mental health support. For instance, one healthcare practitioner stated, "I feel supported that I have somewhere that I can have my patients explore these topics that I know will help their healing in a guided, structured way that is safe for them without me, who is not trained." The other two themes that emerged from these interviews were the learned coping skills from the hypnosis program and how they improved patient outcomes, as well as that the program provided a psychologically safe, psychological safety in the therapeutic relationship. The data from the patient-focused interviews is still being gathered, so stay tuned for the results of the chronic pelvic pain patient interviews. And last, but certainly not least, I'd like to tell you about our mindfulness CBT program that I alluded to before. This is a relatively new initiative within our clinic, and it's a group therapy program. Is delivered by my colleague, Dr. Sinai, who's here today, who learned this therapeutic technique from Dr. Laurie Brotto at University of British Columbia and brought it back to Edmonton for us.
Research knows no boundaries.
Yeah. Mindfulness CBT is a type of therapy that has been described for chronic pain conditions, and specifically vulvodynia, which we do see in our clinic as it's a chronic pain condition specific to the vulva or the outside of the vagina. CBT is a type of therapy that is centered on challenging maladaptive pain-related cognitions, change-oriented psychoeducation, and behavioral interventions. Mindfulness has been increasingly used alongside CBT for a variety of health-related conditions, especially chronic pain. And for mindfulness, unlike the change-oriented approach to CBT, it uses more of an acceptance-based approach. So you can see from my slide, cognitive behavioral therapy focuses on acknowledging the thought and rewriting the script, whereas mindfulness practice is acknowledging the thought and letting it go. Mindfulness CBT studies in patients with vulvodynia have shown significant improvements in pain self-efficacy, pain vigilance, pain catastrophizing, allodynia, sex-related distress, and mood endpoints. You can see Dr. Brotto's name on multiple studies that I've pasted here. So far, we have seen significant success with this initiative, and Dr. Sinai is hoping to study and expand its effectiveness to other pelvic pain conditions, including myofascial pain and other gynecological pain syndromes, and to study the virtual delivery of our program in order to reach more patients and overcome geographical barriers in collaboration with Dr. Brotto. So this about sums up where we are, where we're hoping to be, and what we are studying. Again, thank you so much for this opportunity to showcase our efforts here at the Chronic Pelvic Pain Clinic. We are extremely grateful to the Women's and Children's Health Research Institute and the Alberta Women's Health Foundation for their ongoing support and facilitation of our projects. I'd be happy to answer any questions.
Questions till the end. Thank you so much, Dr. Kelly. In the interest of time, we are going to hold questions until the end. So I would like to invite Dr. Luis Nacul to turn on his camera and to present on research-driven innovations for ME and CFS and other complex chronic diseases. Dr. Nacul, can you hear me?
Hello. Yes. Hi. Can you hear me well?
Yes. Can you adjust your camera slightly? There we go. Perfect. Just let me know and I'll change your slides.
Okay, great. Thank you very much for the opportunity. Good morning, everyone. So I'm going to be presenting about myalgic encephalomyelitis or chronic fatigue syndrome. And I appreciate that not all of those in the audience will be familiar with this disease. So I'll start by giving a very brief overview of what ME/CFS is and present some challenges for research and clinical practice before I move to international guidelines and also how we can improve diagnosis and treatment through research. The next slide, please. So we define ME/CFS clinically. So ME/CFS is a complex chronic disease, which is debilitating and characterized by profound fatigue, which is worsened by activity, both mental and physical activity, plus post-exertional malaise, unrefreshing sleep and other sleep disturbances, and cognitive difficulties, in addition to pain, which is usually widespread and can be mostly felt in joints and muscles, as well as autonomic dysfunction. It is a disease that affects all age groups and all sexes. However, it's predominantly a women's disease. The ratio of women to men is 3-1. So about the same ratio of presenters here in this event today. And it tends to peak towards the end of adolescence and then towards at a later age in women. In terms of pathophysiology, something that's still evolving, but the general understanding, I'll be very brief on that, is that all starts with a trigger or insult that it's more often than not is an infection. Mm-hmm. And this insult or stressors will lead to abnormalities in the immune function, central and autonomic nervous system, circulatory system, and metabolism, including energy metabolism. So it is a multi-system disease. Next slide, please. And the first, if you look at the left side of your screen, you'll see our data on the risk factors for ME/CFS, and this data is before the pandemic, and you can see I'm just highlighting that infection had an odds ratio of 25 for in association with ME/CFS. And so that's something that we have known for a long time, and the illness has been called previously, among other names, by post-viral fatigue syndrome, because it was so commonly observed after viral infections such as herpes virus infection and also arbovirus infections and even bacterial infections and others. So it's typically triggered by an infection, and our data showed about 2/3 of cases there is a reported infection starting the symptoms. So it's not surprising that long COVID presents as ME/CFS in many cases and in most cases. So the other figure here shows in red the symptoms, different symptoms that are found in people with long COVID, and how they compare the symptoms by people who have long respiratory infections, which are not related to COVID, or people who trigger their ME/CFS through other respiratory infections. And you see there is a big overlap of symptoms. And the blue line shows people without previous infection. So this illustrates how long COVID actually, in many respects, or at least an important subgroup of people with long COVID present as ME post-infectious CFS, ME/CFS post-infectious. Next slide, please. So there are many challenges that we face as researchers and clinicians. There is an incomplete understanding of causes and pathophysiology, although we advance a lot on those. There is no diagnostic test. The diagnosis is clinical. There are no established biomarkers, no evidence-based curative treatment, and the recovery rate is pretty low. So the statistics shows that beyond the initial stages of disease, perhaps in the first year, recovery rate or full recovery rate is about 5% only, although many people can improve significantly. This reflects, from the patient's point of view, and the data reflects or shows some results of our patient-oriented research, which show us that patients find the illness very isolating from the social point of view. There's a lot of stigma that they need to face, and they have great difficulties in getting diagnosed. This is a lengthy and challenging process. Next. I'll now move to recent guidelines on ME/CFS, and all these 3 guidelines came after 2020, and they include a nice guideline from the UK, which is used in the UK Health Services, as well as the American guidelines from a group of prominent doctors there and other health professionals, as well as the European guideline. That was based on expert opinions from researchers and clinicians from 21 countries in Europe. So just giving a highlight in the next slide of the NICE guidelines, there are three main findings there that I'm highlighting in blue here. First, that the diagnosis is clinical, and this requires a history, physical examination, and exclusion of other diagnoses. And this, of course, is due to the lack of a diagnostic test. So, as I said, it's a clinical diagnosis. And unfortunately, the evidence for interventions is pretty low or very low quality. So research has not been forthcoming. Funding for ME research has not been forthcoming. Perhaps after COVID, we'll learn a lot through the long COVID, which applies to ME CFS. But until then, there has not been enough research to allow us to come with strong evidence of interventions. However, a main strategy for symptom management is reported by NICE as being energy management. And this means avoiding physical or mental exertion beyond the energy available to the individual. And this is what is called very often the energy envelope, that people live with a restricted energy envelope that potentially they can expand over time. And so this slide from the US group shows shows the people who keep themselves pacing and within the envelope, they tend to reduce their fatigue scores over time. And this doesn't happen with people who don't follow or to push themselves beyond the energy envelope. So this demonstrates the importance of pacing as a strategy to improve the illness long-term outcome. At the same time, NICE is quite it's quite direct in the fact that there are no curative treatments. So it cautions again use of CBT, exercise therapies, or even medicines and supplements in the treatment of ME/CFS, although they recognize the supporting value of some of these measures. And the next slide will show some of the highlights from the Euromean, which in a way is a bit more proactive in proposing symptomatic treatment, but at the same time, it highlights the importance of supporting patients to be empowered to control their symptoms, and again, highlight pacing as a key strategy. The next slide will show some examples of treatments that can be used, in this case, for different symptoms such as sleep difficulties, pain, dysautonomia or autonomic dysfunction, which can be characterized clinically and is treatable, as well as medications to target inflammatory processes and autoimmunity as well, and allergy-related symptoms such as mast cell activation syndrome. The next slide will show now moving to how research can help improving diagnosis and treatment. So starting with diagnosis, we can see the figure on your left-hand side of the slide shows what we have done with patients. We asked them to press this dynamometer using maximum force with their dominant hand for 3 seconds, and then we asked them to wait for a minute, and then repeat and repeat again 3 times. So what we can observe there, at the very top, is what happens with healthy controls. So they have a relatively high strength or hand grip strength, which is quite stable following the three times when they use their maximum force to press the piece of equipment. But and close to them are people who have chronic fatigue, but which are not ME/CFS. And then if you look lower down, you see people with ME who have milder forms, people with MS, and then at the very bottom that you have people with severe ME or severely affected by ME. So you notice that particularly for the severely affected, the hand grip strength is much lower compared to healthy controls in individuals of milder forms of the illness. It's quite specific for severely affected participants in the trial. And however, there is another thing that we notice is that when you go from the first to the second and then third trial, the hand grip tends to reduce differently from what happens with controls and people with MS and other forms of chronic fatigue. So there is a fatigability there, because when you try to repeat the exercise soon after the first time, what happens that you are less able to produce strength. And then if you look at the two other slides, is what the group in Germany did more recently in 2021. Actually, they asked patients to press, and controls to press the dynamometer for 10 times repeatedly. And then they asked patients to wait for 1 hour and then repeat the test. So the upper trace reflects what happened in controls. There's not much change from the first to the second or to the repeat values. If you look lower down, you see what happens to people with ME. The first time they use the equipment, the first trials, there is a slight reduction in force as they go from the first to the 10th. Trial. However, the second time they do, which is after 1 hour, you see that the values of the hand grip are lower throughout. And actually, they found that when they look at the mean of the second trial or the second set of trials, they found it to be quite specific for diagnosis of ME/CFS. So this is a simple test that can be done by the bedside, or when a patient comes in the ambulatory, you can do those tests and they help with the diagnosis and also characterization of severity of the patient. The next slide will show what happens with the data when you look at the data of creatine phosphokinase, which is can easily and very cheaply be obtained by standard blood tests. When you look at people with ME, controls, and those people with ME was divided into mildly, moderately affected, and those with severe ME. And you can see that the more severe the cases of ME, and anyone with ME actually will have lower values of CK. CK is an enzyme which is involved in muscle function and metabolism, including energy metabolism. So that's the findings that we have. And people who do clinical practice on a daily basis, they will more often be observing high values of CK as indicating pathology. In this case, the low values are those of interest. And the receiver operating curves show that if we compare the severely affected with control, the CK values have 83.7% area under the curve, so which indicates quite good sensitivity and specificity to detect particularly the severely affected cases of ME. The next slide, please. So let's move to treatment. And I just mentioned the treatment according to guidelines. And what we do at the CCDP clinic here in Vancouver at BC Women's is we use a multi-professional approach, which includes the clinical assessment and treatment, or medical assessment and treatment. At the same time, we provide a number of group activities by our interprofessional team in support of self-care and for education purposes. So I believe there is some overlap between our program and what happens in the chronic pelvic program as just presented, and certainly there are overlap with chronic pelvic program here, chronic pelvic pain program here in Vancouver. So this is just a snapshot showing that when we look at the SF36, which is a very well-known indicator of quality of life and functionality, the physical scores tend to happen as from the baseline and as they move to the program until discharge, and the same happens with the mental health summary indicators. So it shows some benefits of the program that usually patients are involved in for about 12 months. The next slide will show just some treatments that we have been offering here in our program, which include medications that may affect the neuroinflammatory changes that are observed in people with ME as well as in fibromyalgia. And this includes the low-dose naltrexone, which we have been using extensively for some years in the program, and there is some success with a proportion of patients at least, and the graph shows improvement in pain scores as well as improvement in the PHQ-9, which is an indicator of psychological or depression, psychological mental health and depression in particular. But it's interesting to note that the PHQ-9 has quite a few questions which are related to fatigue and which overlap with the symptoms of ME/CFS. The other figure shows actually data from Stanford in the US, and this is the results of the use of aripiprazole, which is originally used as an antipsychotic, as most of you will know. But what happens is when it's used in very low doses, we believe that they are good modulators of dopamine, as well as they have an anti-inflammatory effect in the glial cells in the brain. And 74% of the patients in their series responded well to aripiprazole in terms of fatigue, brain fog, and unrefreshing sleep, which are key symptoms of ME/CFS. Next slide, please. We are now starting or about to start a trial of low-dose naltrexone on people with post-COVID fatigue syndrome here in Vancouver in collaboration with the post-COVID recovery clinics. So this is still going to happen. We hope to have something more to tell you in about a year's time on the results of this trial. Do I still have a minute or two to complete?
No, actually, we're at time.
Okay.
But thank you very much, Dr.
Well, can I just show a concluding slide?
Absolutely.
So you can jump this one.
Yes.
And I just wanted to conclude briefly saying that as understanding of causes and disease mechanisms evolve, it will be possible to improve diagnosis and develop specific treatments for ME, long COVID, and other subgroups of ME. In the meantime, patients can be helped a lot by following existing guidelines on diagnosis, management, and treatment. So there are guidelines on how patients can be helped. And at the same time, of course, we can and we should accelerate research not only on biomarkers discovery, pathophysiology, and treatment as priority areas. And it's very important to educate, train, and develop disease pathways as strategies to reduce morbidity. Thank you very much.
Thank you very much. And thank you for your work developing such practical and easily available diagnostic tools. Can I ask one question? How long on average do people seek a diagnosis before they get one?
That's a very good question and illustrates a big problem in terms of recognition of the illness and also the lack of understanding or lack of training of people in primary care to diagnose. The patients that we receive here, I don't have a precise figure, but I can tell you we're talking about years, not months, until they reach us. So it's not uncommon to see patients who have the illness for 10 years or 15 years until they reach our specialist services. So very often they'll visit many specialists until a diagnosis is made. So I think, and that's why I think this is so important. People should be, professionals, health professionals should be actually empowered to make diagnosis early. And this is not difficult if you use clinical criteria that is currently available.
Thank you, Dr. Nacul. Now, I'm very excited to welcome Dr. Rachael Bosma from Women's College Hospital and the University of Toronto to speak to us about rapid access to care for people living with pain and the development of a digital platform. Dr. Bosma, the floor is yours.
Thank you so much. And thank you for this opportunity to join you all to talk about something that I am very passionate about, and that is access to pain care. So I want you to pause for a second and think about yourself in pain. And for some of you, you might not have to think too hard. You might be one of the 1 in 5 Canadians that struggles with chronic pain every day. But think about yourself in pain. What do? If it's really bad, chances are you seek treatment of some kind. Anything to make it stop. But let's say it doesn't stop. Let's say the pain goes for months and months. And well, the pain is the pain, and it's disrupting everything in your life. It's disrupting your work. It's disrupting your relationships. And so you keep seeking answers. You go to your doctor, you get a referral, you get put on a wait list, and you wait. And you wait. And you wait. And the reality is that this is a reality for many people. And I mentioned 1 in 5 Canadians. And while chronic pain is poorly understood, and right now there's limited resources available to help people manage their pain. Next slide, please. But when we think about who this is really a reality for, who is waiting for pain care, we're really talking about women. We're talking about mostly women and people who are marginalized. Because there's a gap here, there's a health gap. Women have higher prevalence. This is true of most chronic pain conditions. Women have a higher prevalence. There's higher rates of disability, and the pain is worse. And on the other side of that gap, patients up to relatively recently, women were excluded from research. So we don't actually understand a whole lot about women's pain and women's pain experiences. Women can often be not taken as seriously about their pain, and they have less access to pain care. Next slide, please. And I care a lot about how we can change this. And I'm privileged to work at Women's College Hospital, where we all care a lot about how we can change this, how we can improve access to pain care. And we're doing a lot to change this. I work at the Toronto Academic Pain Medicine Institute. This is a partnership of 5 different hospitals, 5 different institutions across Toronto, and we've come together to streamline pain care. We have a common referral and triage hub, so all the paperwork comes into Women's College Hospital. So that just means that if you're a patient and you're seeking specialist care in Toronto or the GTA, there's one place to send your paperwork. And we sort out kind of on the back end where you need to go, where you can access specialized care that will address your needs. Next slide, please. And having the paperwork come into one place allows for better service delivery. And so I've illustrated here on the slide a number of different ways that having this common referral and triage process is an advantage. But I think importantly, it allows us to take a close look at who is getting access to pain care and who is not. So next slide, please. And so I'd like to give you an example, and the example is chronic pelvic pain. So it was about 2017, and in terms of who is and who is not receiving access to pain care, it was women who have chronic pelvic pain. Because at the time, there was no chronic pelvic pain services in Toronto or the area. And within 18 months, we had over 300 referrals accumulate, demonstrating a significant need for this patient population. So we did something about it. We sat down, we allocated resources, we created an interprofessional pain program, pelvic pain program, and we provided access into services for these patients. But again, back to the waiting reality. A lot of patients wait. And this is true, wait for pain services. And this is true in our pelvic pain services, but this is true across the board. And not only in our own clinic, but across the country. People tend to wait for specialized pain care. People tend to wait for interprofessional pain care. And we're talking months and sometimes years. Next slide, please. And when we think about waiting, many of us, we're impatient, but people tend not to get better while they wait. They tend to do things like put their life on hold. It's painful. They're not going to do anything until they get this addressed. And their health typically deteriorates. So their health is going down. And meanwhile, as they're waiting for this specialist care appointment, they're waiting, their expectations are soaring. Because this appointment, this is going to have the answer, this is going to have the cure. And then they walk into our clinic doors and they learn. And often for the first time, they are told that they have a chronic disease called chronic pain. And right now we don't have a cure. But there are a lot of things that we can do. There are a lot of resources and programming and support that can help people manage their pain better. and function better. And so our team on the ground was thinking, why are people waiting? Why do people need to wait to learn about their disease? Why do people need to why do people need to wait to get access to resources, to be able to communicate what they're experiencing, to have skills and coping strategies that they can implement now? And so we talked with our colleagues across the province, and there was, this resonated, and there was a lot of appetite to get together and do something about this. Next slide, please. And so we worked together interprofessionally. So we had a team, it included doctors, psychologists, nurse practitioners, OTs, PTs, researchers, and importantly, people with lived experience. And we worked together to create a self-management program. It's an online self-directed self-management program. We got away from the language around self-management and termed it empowered management. You can see here the list of topics, and this is an interactive presentation, so I invite you to take your phone out if you have it available. This QR code will give you access to one of the modules if you're interested in taking a look at what we came up with. But we worked together to say, what can we put in the hands of patients early? They're interactive modules. They have animated explainer videos. They have interviews with people who are living a chronic pain journey and chronic pain management journey. And for those of you that are interested, we also did a series of these for the chronic pelvic pain patients as well. Next slide, please. But then, as many research projects go, we got the grant, we created the project, we did the study, we wrote the paper, and we moved on. But wait, we were trying to get access. We were trying to improve access for pain care. So how can we actually get this in the hands of people who need this program? And in fact, when we started thinking about this is likely true of so many existing resources, so many evidence-based. We invest, we do the research, we know it's good, we know people like it, we know they'll use it. But then we're done, and it's hard to know how to get it to patients. And we recognize that there's a lot out there, but it's also hard to know what can you trust and where do you find it. So we went another step further to improve access to pain care resources. And we again worked with an interprofessional team from across the country, co-led by people living with pain, to co-create the Power Over Pain portal. Next slide, please. And I, again, invite you to follow along. You can look at poweroverpain.ca. I encourage you to take a look at our portal. The QR code is there. So what is Power Over Pain? Well, we describe this as a one-stop shop because we've integrated evidence-based solutions. And this also helps us to understand, where are the gaps in solutions? What do we need to work towards? We have an adult portal and a youth portal, recognizing that chronic pain doesn't discriminate necessarily by age. It spans the lifespan, and that there's different evidence bases and there's different approaches for different age groups. We offer a range of services from low intensity to high intensity, recognizing that everyone's different. Their pain management journey is different. Their capacities, their interest right now, their capacity right now, their preferences and their needs for right now are different and might change over time. So we have things such as, static information, podcasts. You can come out, or we have things where you can invest a little bit more deeply and take self-management courses or counseling, etc. And we've also worked to include mental health and substance use health resources, recognizing that for some, this is part of their chronic pain journey. Next slide, please. And so this is just detailing the people driving the portal on the adult side. Next slide. But here are the people really driving the agenda. This is our lived experience advisor that we co-create everything with to make sure that it's all relevant and accessible. This is on the adult side. There's a whole different advisory on the youth side. Next slide, please. And this is just a quick snapshot of all of our partners, showing you that it truly takes a village to do something like this. Next slide. And so I hope you had a chance. You have a device with you. You can look at poweroverpain.ca. When you go into the adult side of the portal, what you see when you click on that, your portal, your way, always free. So a quick note on that. We've worked hard to integrate not only evidence-based solutions, but solutions that are freely available. Understanding that our goal was to improve access to pain care. So nothing behind a paywall. And it's also importantly conflict of interest free. So this is created by trusted academic institutions and is currently funded by Health Canada funding through their SUAP program. Next slide, please. And so here's a preview to all of the different kind of categories that you can access when you look at the portal. So just quickly to look through them, if you go into Orient, this takes you to an explainer video that kind of showcases the different features on the portal, why we made it, how we made it, what you can do with it. Learn is a repository of different resources to help you learn about your pain and different factors that influence your pain. And again, across the spectrum of, some just static information all the way up to self-management courses. Connect gives you opportunities to connect with peer support groups across the country, recognizing that pain is very isolating. And so connecting people with people who are sharing a common experience and leveraging that mutual support model to support their chronic pain journey. Talk gets you in touch with the professional counselor. Attend. This is a really neat feature where we host live workshops weekly. So this is, they're provided by clinicians within chronic pain services across the country. Anyone can just register for these and come. There's a Q&A, much like this webinar today. And then there's an enroll feature. So there's a lot that you can access without giving any information. But if you choose to enroll and set up an account, then there's also additional features in this portal, including our track feature, where you can take check-ins and follow your pain. And I'll share a little bit more about that. Next slide, please. So diving a little bit deeper into our Learn bucket. So there's a lot of different resources you can see here. We've got search functionality. You can look at, what is interesting you today. And you can also look, oh, hey, I want it in a podcast, or I want it in a video format, or I want it in a course format, etc. But these little fireworks here beside the Empowered Management Program, that's to remind me to share how excited we are that this is our Empowered Management Program. So this is a program that we created, and then we got done the research and we went, okay, now what? Well, this is what, and it's now being shared across the country as part of this larger platform. Because again, our intention was to have an impact in the access to pain care, not just to conduct research. So we're really excited to be able to share this resource and other resources in this way. Next slide, please. And as I mentioned, this portal is more than a website curation. And this is one feature and so this is our track feature. This allows you to take check-ins to assess where you are in terms of your pain. So on the back end, this looks like, very common pain questionnaires, sleep questionnaires, mood questionnaires. On the front end, it's very patient-friendly. But what it does is allow people to interact and track their symptoms over time, track their progress over time. And I share that this is really an important thing to do to understand your own pain better, to communicate your pain better with your clinical team. Say you got an intervention, is it nudging the needle? Is it doing what you're hoping it's doing? And actually having kind of an evidence base in front of you. So it tracks it, it graphs it, it gives you an interpretation. Well, what does that score mean? What do I do with this information? And importantly, based on your scores, we are able to tailor and kind of personalize your experience. So what I mean by this is, for example, if you indicated that sleep was, your sleep was terrible through the questionnaires, it would come up and say, oh, based on your sleep scores, maybe you'd be interested in the following recommended resources on the portal. So it also guides and personalizes your experience on the portal. Next slide, please. Okay, so we built this portal, we built this platform. People will come. It's not quite that simple. So we've been doing a ton of dissemination and implementation work to really get the portal in the hands of Canadians. So we started with the people that we know, and this would be in pain clinics and pain networks. And we asked them, how can we get this we asked them to share the portal, get this into the hands of your patients, and also think about how you can integrate it in your clinical workflow and as part of the clinical programming that you offer. We've shared it broadly across clinical and research communities through presentations, orientations, conferences, and we're working on getting it out into the general public through marketing strategies. Next slide, please. So how are we doing? Since we had a kind of a hard launch in the summer, we've reached almost 30,000 people, and you can see that we're having both national and international reach. Next slide, please. And we're looking to enhance this access through enhanced capacity. So we're leveraging staff to build capacity to reach more people. So for example, those that attend that workshop that I showed you that we're sharing workshop opportunities. You can take weekly workshops through the portal. Well, these workshops could be also, or once were, given in a clinical setting. So say in your clinic, you give this, maybe you have 8 people enrolled in the program, maybe you offer it a couple times a year. Well, through the portal, we can offer this much more often by rotating clinicians, because each site was offering very similar foundational programming. And we said, well, if you've all got it, let's put it on the portal. Let's increase access, increase capacity. Next slide, please. And we're decreasing wait times. And so this is an example from our own clinic where about 50% of patients were waiting for more than 6 months to access our education program. And now they don't have to wait. They can access it rapidly through the portal. Next slide, please. We're also streamlining services. So we're taking a look. So the example that I can give is in our own pain program. So we took a look and said, hey, 5 years ago when we just started and there was not a whole lot out there, we had to build everything out from the foundation. But now that we have partnerships like this, and now that we've built and these tools, we can leverage them. So programs that were once offered in a clinical setting have now been sunset because they're now offered through the portal. And so our patients, it's very important that our patients still have access to the array of services, but it's not as critical that we deliver them at each site, and we can take more of an equity lens. When do we need to, who do we need to deliver these services for? And we can give back time, invest back time into our programs to dedicate clinician time to offer pain care for complex patients. Next slide, please. And as you can imagine, this also results in healthcare savings. And so through the portal, we are increasing access to pain care, we're decreasing wait times for this access, and we're streamlining service delivery. Next slide. Okay, so I've taken you on a journey from identifying the need to get patients better access to pain care, to creating a solution, testing the solution in the Empowered Management Program, to building a platform such that it could be shared and we could integrate evidence-based solutions through the Power Over Pain portal, through dissemination and implementation of this portal. But the journey's not done. And there's a lot of opportunities and work to be done to ensure that these resources continue to be useful and used. And so this is my call to action. I invite you all to join us on this journey. Use the portal, provide feedback, recommend it to others, integrate it in your clinical program. And I don't have this on the slide, but fund the sustainability of the program. Offer financial resources to sustain these services, and importantly, help us improve access to pain care across Canada. Next slide, thanks. And so with that, I'd just like to thank you all for your time and your intention and invite questions. Thank you.
Thank you very much, Dr. Bosma. Let me stop sharing. Now, actually, I don't know. If the panel would all like to turn on your cameras at this point, are there any questions in the room? I'm very inspired. We've heard about how these clinician-driven research programs are scaling up both capacity and access in terms of diagnosis and treatment, and having some real health system benefits as well. Was there anything that anyone in the room wanted to ask about? Okay, I'm a little bit bewildered by this tech this morning. The tech is making me afraid. Yes, Laura, you're going to have the mic. Just one sec.
Hello. Okay, thank you so much for your presentation, Dr. Bosma. Is there a way that we can get printed material from the portal to get to our pain clinics? So like the QR codes that we can use in our clinics, because to have them there offered to our patients?
Absolutely. Yeah, thank you so much for that question. I couldn't have planted it better. Absolutely. So poweroverpain.ca, the portal's live. It's free to access across the board, but we also have a lot of dissemination material. So we have brochures and posters and cards, and I'm happy to share my contact information. If you're interested, we're happy to pass along these so that you can get it in the hands of your patients. But outside of that, if you remember poweroverpain.ca, that's your ticket in to look at all of the resources and share them with your patients. Thanks for the question.
Okay, so I don't see any other questions in the room. So I will, just as we close, ask in 1 minute if each of the speakers, and Rachael, because you're on the screen, perhaps you could start, could reflect a bit on your experience working in an interdisciplinary setting and why this is critically important for this, to address this patient population.
Yes, absolutely. I can take a first go at that. So I should disclose also that I'm a chronic pain scientist, so I'm not a clinician, but I'm embedded in the clinical program. So also to encouraging everyone, I saw, research lead, that's my job title on the wish list, and just to encourage everyone to think big. So why is it important to have an interprofessional team? I think it's because pain is complex. Dr. Kelly talked about the biopsychosocial approach. So there's many different factors that influence our pain. There's biological, there's physical, right? There's psychological, there's social factors. And so we need complex treatment approaches, and we need interprofessional treatment approaches. And we need to look at this from a number of different lenses, because we know that there's not a magic bullet. There's not one medication. There's not one, that it really takes a team. And so we need a team-based approach, and we need it to be highly integrated. So not just a siloed, okay, it's my turn today, your turn tomorrow, but really creating innovative strategies around patient care and around care planning for individuals to really meet their needs and understand what their needs are as they evolve, and really approach them. I think holistically was really presented nicely today. Approach pain care holistically.
Thank you. Dr. Nacul, do you have anything to add?
I think Rachel said it all, but I'll just reemphasize what she said. The same for pain applies for fatigue. So if you have chronic pain, you have chronic fatigue, you have a disability very often. Social workers are very handy on that. You have difficulties with your studies or your employment, so occupational therapies are important there. You have the psychological impact of living a chronic illness, so counselors have a role. So it's a multi-causal and multi-phased illness. So those illnesses are, and this requires a multidisciplinary team, and that's what we do here. That what other presenters here do their clinics, and I think that's the right thing to do and very important.
Dr. Munro, I know that you're coming from a different perspective, but also do chronic pelvic pain care. Do you have anything to add?
Yeah, that's what I was going to say. When I'm not dealing with acute care of labor analgesia, I do spend time in an interdisciplinary chronic pain clinic. And I found this panel very useful. I was taking notes, and I've, signed up to the the portal already. And I think it's because it shows that, interdisciplinary care is the evidence-based suggestion for dealing with chronic pain, specifically chronic pelvic pain conditions. And I noticed the wish list that was up there, and I was adding my own wish list, because you always want what you don't have. So we're lucky we have research leads, but we wish that we had more dedicated CBT, and there's always the interdisciplinary panel seems to never could be endless, because as we mentioned, that dealing with chronic pain is so difficult, and it has to be multifaceted, and you have to have experts in all areas. So the wish list is long, but I think it really works to share these resources to be able to not duplicate resources and make use of what we have.
Dr. Kelly, you have the last word.
I'm not sure I have that much to add to what everyone else has said, because it's been really well covered. But as a clinician treating patients, For sure, you can see a huge difference if you are only treating the very small medical, biological aspect of pain. Patients are barely surviving appointment to appointment, and you can see a radical change when they've had access to all the other interdisciplinary and multidisciplinary treatment modalities. They start to thrive and be empowered and develop their own self-efficacy, which just sort of feeds forward to the treatment of their pain and reinforces the medical treatment of their pain. So it seems impossible to do without these, without a multidisciplinary and interdisciplinary approach.
And thank you all so much for spending this time with us. Another round of applause for our panel, please.